Hi guys, this is Dr. Shannon Clark with Babies After 35. We are going to go live at 1:30 to discuss everything you want to know about labor and delivery but are afraid to ask. I'm waiting for, sorry if I hear in my mouth. I'm waiting for Kacy Dyson, a labor and delivery coach, to join me soon. And as soon as I see that she's joined, I will ask her to join us. Let's see if she's on yet. Not quite yet. So again, we have 4 more minutes, so be patient and then we'll start. There you are, Kacy. I'm going to request you, so hang on. You should be getting a request, Kacy, if you're on. Ah, I see you're coming. Hi, Kacy. How
How
are you?
are you? Good.
Can you hear me okay?
Yes, can you hear me?
Actually, I might put, do you have headphones? I might put headphones in. So one of us,
Yes. Go grab.
it might be better. We have a few more minutes before we need to start. Let me just see if these headphones work better. Sorry guys, I'm trying to untangle them.
Well, maybe I don't have headphones. Maybe.
We have a few more minutes, guys, before we can join. Can someone just tell me, while we're waiting on Kacy, if anybody's listening, can you just shoot me a comment and tell me whether or not you can hear me okay?
Okay. Sorry.
Perfect.
Does
So then I know
sound
they
better?
can hear me. I hook in so because I can't really hear. So hook in with the headphones and see. We've got 2 more minutes before we start.
I may have. Better?
Much better. Much
Woo!
better.
There you are. Woo! Better on
Okay.
my end too.
Yeah. A lot of
Okay.
times, if we're not on headphones, I found you get a lot of delay or echo. And so it's
Okay.
better. And I'm sorry, I forgot to tell you to get headphones, but it's okay. That's why I wanted you to come on early so we could work it out. So, guys, we have 1 more minute before it starts. And the way this is going to work, we'll start right out with the formal introductions of myself and Kacy. And then I have a whole list of stuff here that we can cover, and we'll just start covering topics until people start asking questions. I want to keep it to about 45 minutes because I want to be able to save this. And if you go beyond an hour, then I can't save it. So we're going to try to keep this to 45 minutes. And I have a little timer so I can watch. All right, we'll go live. We'll go start in about a minute.
Wow, I can't believe headphones make that big of a difference.
Yes, for
I mean,
sure.
it's amazing.
Yeah, I just ordered some new headphones actually because I find that the actual ones that are specifically for iPhone work the best. I don't know why, but it's probably designed that way, I'm sure.
Yes, I'm sure there's something behind that.
Uh, okay, it's 1:30. So we're going to start because we want to use every bit of our 45 minutes we can. So I am Dr. Shannon Clark. I am an OBGYN and a maternal fetal medicine specialist, and I'm also the founder of Babies After 35. I found Kacy Dyson. I think I found you on TikTok, or we connected on TikTok
Mm-hmm.
somehow, and then ended
Yep.
up going over to Instagram. So Kacy, introduce yourself. Tell us what you do, where you're at, and also about the Mama Coach.
Okay, my name is Kacy Dyson. I'm a registered nurse. I am a wife and a mom of 2, And I actually work in labor and delivery. So my full-time job is being a mom and a wife, but then my other full-time job is being a labor and delivery nurse. And then I also own the Mama Coach business, which is something that came about after I had my kids. I got home, and me being educated and a nurse, I got home and I thought, oh my goodness, what do I do with these kids? And how do I breastfeed? What do I do? And even
Yeah.
though I was educated and was teaching women this every day, I got home and was so lost. And so that's kind of how the Mama Coach came about. And so what I do is I support women after they get out of the hospital, and sometimes pre-birth too. We do prenatal classes, breastfeeding, anything really that they need. They can get out and reach out to me, and I can teach them and help support them through their journey, whatever that looks like for them.
Perfect. And so how can they find you on social media?
I have a TikTok account, which is themamacoach.kcrn, and I have an Instagram account that is themamacoach.kc, and it feeds over to my Facebook account. And then you can also find me on the Mama Coach website. There's actually 42 or 43 registered nurses as a whole.
Perfect.
And we all have our own webpage through just themamacoach.com. So
Really cool.
you can reach
Really
me
cool.
through
Well,
all of that.
perfect. So now that we know,
Yes.
you guys know who we are. We're going to get started. So the first topic I wanted to bring up, I just want to define just off the top, because I want to kind of gear this talk towards what you want to ask about labor and delivery. Okay. I'm not going to get into medical complications of pregnancy and high risk pregnancy and all of that, because I want to try as much to stick to that topic. So I wanted to define first off what is a term delivery. So a term delivery by definition is from 37 weeks gestation to 38 weeks and 6 days. Then you go to, I'm sorry, early term. Then term delivery is from 39 weeks to 40 weeks, 6 days. And then we have late term, which is 41 weeks to 41 weeks and 6 days. And then post dates is after 42 weeks. So first of all, we'll talk about, I'm sure we have very different experiences, because you are a labor and delivery nurse in a unit with mostly private practice OBGYNs, or do you have residents and everything?
I don't have a lot of residents where I'm at, so we
Okay.
have private practice.
Yeah. So she's in a hospital where private practice doctors deliver their babies. I'm in an institution, it's an academic center where all my patients are high risk, and I work with residents and fellows. So you have a good representation here. So let's just start off talk off the bat just about induction of labor. Tell them what you know about induction of labor.
So induction of labor is oftentimes, it should be 39 weeks and up, typically, unless you have risks or medical issues that your doctor needs to deliver you sooner than that. This is where you could either come in the night before and ripen up your cervix, which means get your cervix soft and ready to go for labor. So get it to start shortening, softening, and opening a little bit, so that we can get you ready for the Pitocin that's going to make you contract. And the contractions are actually going to get you to your baby.
Yeah.
And so what an induction does is just kind of help you get you ready and then kickstart labor.
So generally across the nation, especially based on ACOG, which is the American College of Obstetricians and Gynecologists, and also the Society for Maternal Fetal Medicine, there's been a huge push to do delivery at 39 weeks or more, unless it's medically indicated, meaning there's a medical indication for a mom or baby that requires that she be delivered earlier than 39 weeks, I should say. So we have to really make sure that we make the right decision. Back when I was training, women would come in at 37 weeks easily and be induced. And what we found was those early term babies between 37 weeks and 38 weeks and 6 days were actually having complications in the nursery, because their lungs weren't quite mature. Okay, so that's why there's been this big push over the last several years to consider an elective induction, which means just an induction just because your term, that shouldn't occur until 39 weeks unless there's a medical indication to do it before then. So you'll hear that, but actually there's and I don't know if you've seen this, Kacy, we considered it before elective induction at 39 weeks. Now it's called induction for 39 weeks. That's what SMFM has or suggested, and I am totally for that. The reason being is there's been some new data out that have shown that an elective induction in a singleton pregnancy does not cause any more complications than if she went into labor on her own. At my institution, we offer elective or induction for 39 weeks for anybody once they hit 39 weeks. They don't have to accept that. You don't have to agree to it. That's fine. but our goal is to get them delivered by 40 weeks or a little more, little after that, if possible. We don't like them to get to 41 plus. And how is it where you guys are?
I don't know that they call it that, but I
Yeah.
know the doctors offer it at 39 weeks if they want it. And
Yeah.
then the patient kind of decides, whether that's right for them or not.
Right. And
So,
same with us. It's not like we say you have to come in. We talk to them about it and say, at 39 weeks you are entitled, and we do offer an elective induction for 39 weeks. It's going to be hard for me to get off that terminology. So, and
yeah.
like Kacy said, once you come in, your cervix will be examined. And just because you're a first time mom doesn't mean your cervix is going to be what we call closed, thick, and high. Sometimes they come in, it's actually, more favorable than we think. Every institution has different methods for induction. We can do mechanical induction, and that's usually, we use Foley bulb or Dilapan. What do you guys use?
We use Cytotec Cervidil, and
Well,
we
for
have it where I'm at right now.
yeah. So that's like the medical part. So yeah, so Cytotec, Cervidil, there's other medications you can be given, but what's called mechanical dilation, that's when you use like a Foley bulb or a catheter,
Right.
or the Dilapan, where it actually goes into your cervix. So yeah, and we also do those too. It all depends on what the cervix is, and the doctor makes the decision as to what they think is best to get that patient induced. And then once the cervix starts opening up, then they determine when and if, because sometimes women kick into labor on their own and you don't need Pitocin. But when and if the Pitocin is needed. Agreed?
Right. Yep. Yes.
Yeah, yeah.
So
So
we don't use Foley bulbs where I'm at, but I did
that's
in Plainview.
yeah. So that's pretty much all we use are Foley bulbs, and then we're using Dilapan more because there's a new study coming out with Dilapan. Okay, is there a topic you want to cover? We'll bounce back and forth. And one of these questions: how about we discussed induction of labor? Just talk about epidurals.
Epidurals are awesome, I think, and it's totally up to the mom's preference whether or not she wants it. I get a lot of patients coming in and they're very iffy on the fence, and they have a lot of education that's wrong. They think the needle's going to stay in their back. They think they're going to have a whole lot of back pain afterwards, which you're going to be sore after an epidural. You did get stuck in your back. But ultimately, it's the mom's decision whether or not she gets that. And the thing with epidurals that I always like to really let them know is that it does last the duration of your labor, unless sometimes every now and then you labor really fast and your body just can't keep up with that. But typically your epidural lasts the entire time, and you're comfortable. The needle does not stay in your back. The needle comes out. It's a tiny little tube. It's comfortable, and then you just get to relax
and through the tube,
kinda,
the medication infuses through the tube as you go through the labor.
yes,
The other thing, as far as one thing you should ask your doc when it gets closer, this is not something you should ask in the first trimester. As you get closer to say 32, 35 weeks, asking what options there are for pain control, because there are other options. You can do IV pain medications. There are some places that are doing the nitrous oxide. We don't do it specifically, but I know some places across the nation do it. So there are other options besides epidural. Again, it's just, I want to reiterate, it is the patient's choice, just like Kacy said, whether or not she gets an epidural. And, it's not her partner's choice. It's not her mom's choice. It's not her friend's choice. It is her choice. That's what I want to say. I see there's a lot of women who I can tell want it or may not want it, but are getting pressure from somebody in the room. So just remember, it's your body and it's your choice.
Absolutely.
Epidurals do sometimes fail, or they get a hot spot. Every woman's different, and the anesthesia will determine whether or not an epidural needs to be replaced. But there are some complications with epidurals, and the anesthesia should explain those to you. But I have found that, and sometimes, especially in first-time moms, and you could, elaborate on this, because you're one of the nurses, you're with them from the very beginning. They're so tense, especially if they're having painful contractions. Once they get the epidural, everything just kind of relaxes, and here comes baby.
Yep.
Yeah.
Absolutely.
And I don't know what it is. I think it's more of a muscular thing and the tension part, but I've seen that happen so many times.
Yes,
And
I had a
Go
case
ahead.
like that yesterday. She was 4 centimeters and she was tense, and she got her epidural, and 2 hours later we pushed and we had a baby, which is super fast, and that's not common, but it happens. And so I always, I have moms that don't want to have an epidural, but they get in a place where their baby's positioned wrong and they're miserable and it's been
Mm-hmm.
hours.
Mm-hmm.
And I don't usually push an epidural, but I will mention to them,
Mm-hmm.
sometimes just think about this,
Yeah.
and I give them that scenario. And
Yeah.
sometimes they take it and sometimes they don't, but more often than
Right.
not, they'll take it and they're thankful because they
Right. Right.
relax. They get a little
Yeah.
snoozy before the baby comes
Mm-hmm.
out.
They can take a little nap and then
Take a
they're ready
little
to
nap.
push. And
Yeah,
then ready to push. So I agree.
there
I
you
see
go.
that all the time too. So somebody
Hmm.
asked, why not the nitrous oxide? It's not that we are anti nitrous oxide. We just don't, not every institution offers it. It used to be
Right.
used a lot back when my mom, 40 years ago, 30 years ago. I'm not sure why. It maybe because of epidurals being more available. I'm not sure why, but now it's starting to kind of reemerge as an option. And I know it's not at every institution. So to be honest with you, I don't know a whole lot about it. I know about it like in a dentist office, and I'm sure it works pretty similarly in the labor and delivery setting as well. But again, I'm not anti-nitrous oxide. It's just that our institution doesn't use it.
Yeah,
Okay.
we don't use it either.
Yeah. So let's talk about when you are counseling someone about the signs of labor, what do you say to them?
I often tell them that their contractions, so a lot of times you'll contract early on in your pregnancy, but it will be very irregular, sometimes once an hour, twice an hour, and then come
So while
closer
you're
to
at it, talk about
term.
Braxton Hicks.
Okay,
Just touch on
yep.
Braxton Hicks. Yeah.
So let's go back to Braxton Hicks. Braxton Hicks are practice contractions. They get your body
Mm-hmm.
ready. They even might get your cervix a little bit ready, but they're not regular. They're not consistent. And when I say regular, I mean occurring every 5 minutes,
In a
every 10
pattern.
minutes, and a
Yeah.
pattern. They're
Mm-hmm.
not regular. They come and go. Braxton Hicks can be relieved with water, Tylenol, a hot bath, position changes, walking.
Mm-hmm.
Real contractions don't. They don't go
Mm-hmm.
away. They get harder. They get
Mm-hmm.
stronger. They get closer together, and they
Mm-hmm.
get longer, 60 to 80 seconds typically.
Mm-hmm.
So when you start going into labor, you might start it every 10 minutes, and then an hour later, after Tylenol, water, and a hot bath, you notice you're every 5 minutes, and they're strong, and you're hurting. And so typically that'll. Uh-oh, did I cut out? Uh-oh. I think
You
I'm
cut out a
cutting
little bit.
out.
That's
Can you
okay.
hear me?
Are you by a router by chance?
Okay,
Potentially by a.
I
Yeah, that's
am.
better. Okay, go ahead.
I live out in
Okay,
the
good.
country though. So, but
That's okay.
real contractions, true contractions, they will get stronger, harder, closer together, and they will be regular every five to
Mm-hmm.
10 minutes. So when you
Mm-hmm.
start getting uncomfortable and you're breathing or you're thinking, oh, I just can't tolerate this anymore, it's probably time to call your doctor or go into labor and delivery or call them. We can always
Yeah,
navigate that with y'all guys and
yeah,
help
they
you.
know what questions to ask to kind of tease out what's going on. But I
Mm-hmm.
just want to talk about why does the uterus contract? The uterus contracts because it's made of a muscle, and it's a smooth muscle, and the contraction starts at the top of your uterus and works its way down. The whole point is to stop at the top, start at the top, push the baby down. Okay, so that's kind of how it works. The Braxton Hicks, like Kacy said, are not regular. They're typically not as painful. They can start really early in the pregnancy. You can have Braxton Hicks starting
Mm-hmm.
as early as 26 to 28 weeks, but they are here and there, one day, next day, but they're not every 5 to 10 minutes for 1 to 2 hours, and they don't hurt, and they're not regular. So Braxton Hicks are okay. But again, I always tell patients, if you don't know, it's always best just to call to make sure that someone's on the other end of the line that can talk you through it to figure out exactly what's going on and if you need to come in.
Absolutely.
With the labor, you hear about the baby drops. Um, Baby dropping, that does happen because that does mean that the baby's getting lower in the pelvis. And sometimes baby drops a lot earlier in first time moms. So their cervix tends to thin out first. Whereas a woman who's had multiple babies, their cervix tends to dilate first and then thin out. So they can carry their baby higher. I don't know why. That's kind of
Yeah.
what happens. It is what it is. I don't know if there's a scientific paper that is out there that explains that, but I've been doing this for 20 years. I'm sure you've been doing it a long time. You see it all the time. The baby dropping does not mean you're going to go into labor like in 48 hours. Women can carry their baby really low at term for 1 to 2
A long
weeks.
time.
Mm-hmm. And it can be pretty uncomfortable.
Mm-hmm.
It can be pretty uncomfortable because that baby gets right behind that pelvic bone and it can be uncomfortable. So you hear about the cervix dilating. Yes, that is a sign of labor, but again, if I see a woman at 37, 38, 39 weeks and her cervix is 2 centimeters, she may stay that way for a little while.
For a while.
So, whenever I change, I'm sure you hear the same thing. They're like, well, when am I going to go into labor? I'm like, I don't know. I have
Yep.
no
You just
idea.
never know.
Yeah. There was another
Today,
question.
tomorrow.
Yeah. Back pain. So, talk about what is your experience with patients having the back contractions or contractions in the back?
For me, pregnant women have back pain. They just
Mm-hmm.
do. You're starting to carry your weight in the front of your belly and you have back pain. But people who labor in back pain, I find oftentimes their babies are kind of wedged in there the wrong way. They're
Yeah. Yeah.
instead of their face looking down at the ground, they're looking up at the sky. And so a lot of times we'll say, they're back laboring, and a lot of times their babies will be faced the wrong way.
Yeah.
And so during labor, we try to get them to flip and flop and turn them and get that baby's head to turn face down.
Mm-hmm.
And
Mm-hmm.
so that causes
Yeah.
a lot of back pain.
And the whole mucus plug thing, I was just having this conversation with somebody the other day. So, when the cervix is like a tube, if you think of this is your cervix, this is where the baby is, the uterus up here. So there's actually two openings to a cervix. The internal opening, which is closest to the baby. The external opening, which is if I were to examine you with my fingers, like in a cervical check, that's the first dilation I would see. Sometimes women can have an external os that's dilated, but that internal opening is closed, it's closed. That's what matters. Not what this is, it matters what this is. The internal opening, whether or not that's dilated. So, you go through a pregnancy and there's going to be mucus in that cervical canal. And then as it starts to dilate, that mucus plug may be lost. And actually women may actually have a clump of mucus that comes out, but some women never do. So that doesn't necessarily mean losing your mucus plug, and I'll use that in quotes because it's kind of different for everybody, doesn't mean you're automatically going to go into labor, nor does not losing a mucus plug. Would you agree?
Absolutely. Yes.
Yeah.
Yeah.
I always hear about yeah. Yeah.
Yeah, it
so,
could just be, who knows when it could be.
Right.
Some people lose their mucus plug way early.
Yeah. So I'm going to actually go back and answer some of these questions, Kacy. So hang tight. I don't know if you can see the questions. Let's see.
I can
scroll.
Barely.
Okay. Let's see. I'm going to scroll. There were a few. Hang tight. Yes, so we'll talk a little bit about C-sections. Elizabeth Chelsea 85 was asking if we were going to talk about C-sections, so we will. We'll get there. But if you have a specific question, go ahead and pop it on there. Membrane sweeping. This is from Leah P. Fanner. What do you know about membrane sweeping?
So membrane sweeping is stripping of the membranes. It's painful. Your doctor usually does it. I don't strip membranes as a nurse. That's not my job. But they take that lower uterine segment and separate it from the membranes and kind of stimulate labor.
We lost Kacy. So basically,
Here I am.
Here's your cervix, baby's up here, I'm doing a vaginal exam. If the cervix is open some already, see it's open some, right? My fingers can get all the way up to the internal os. The amniotic bag, I can feel it. So I take my fingers and I sweep between the lower uterine segment or the lower part of the uterus and where the membranes are to break the membranes away from that lower uterine segment. And that kind of stimulates what's called prostaglandins. And prostaglandins are known to induce contractions. Now, am I going to sweep membranes on a 32-weeker? No. So don't ask. I have people all the time. It's not going to happen. Usually the earliest I will strip membranes is 39 weeks. When I was training back in the day, we as residents, so that was in 2000, 2004, we started stripping membranes at 37 weeks. Not so much anymore. We're not as aggressive about that. But if a patient comes in at 39 weeks and she's a little bit dilated, we can get in there. We'll go ahead and strip those membranes and see if we can get things going naturally.
And you will have some spotting and bleeding after that.
And that's important to know too. If someone is stripping your membranes or membrane sweeping, same thing, because they're putting their cervix up in there and they're going and sweeping around, you're going to have some spotting. So don't be alarmed about that unless it's bleeding like a period or as heavy as a period, then you need to let somebody know.
Do you consider sweeping a membrane sweep kind of a form of induction of labor?
No, because I don't think it's as reliable.
Okay. Yeah.
I mean, now I've done some good membrane sweeping in the less than 24 hours that woman came in. But, again, it's not as popular for whatever reason as when I was training. And I'm not sure why. But, I think it depends on how good you are. With more
Yeah.
experience, I think people get better at it. And I know some doctors, that's what they do, and it works.
Yeah.
But, you have to do it a lot to kind of get the technique down. Do
Yep.
patients
I've
get,
heard of women
yeah, go
getting
ahead.
sweeped more than one time, even,
Yeah. Yeah.
and it still doesn't work. And then sometimes it does.
Right, right. Do patients get epidurals prior to Foley bulbs for mechanical dilation? So at my institution, typically not. What we can do is, you need to be a little bit dilated in order to get that Foley bulb in. Okay, or otherwise it's just going to sit in the cervix. So that internal opening up here by the baby needs to be open a little bit for the Foley bulb to get up in there. Otherwise, if it's closed, Foley bulb's going to sit in here in the cervical canal. It's not going to do anything. Okay, but sometimes what they'll do, as long as it's opening a little bit, they just can do it blindly, meaning just without a speculum, or they can put a speculum in and look at the cervix and actually place it that way. It depends on what the doctor's comfort level is. And you said you guys don't use Foley bulbs, right?
We don't.
Right. So typically, no, we don't do that because I don't really think it's needed. Now, I will tell residents, and I'm at a training institution, that if the woman can't tolerate it, we don't do it. We're not going to torture somebody putting a Foley bulb in. It's going to be uncomfortable for a short period of time, but it shouldn't be a process that takes 20 minutes to get it placed. If that's the case, we need to abort that and find something else. So the answer to that question, Kim Harrison 65, is that no, we don't typically do an epidural product because it's a little too early to place an epidural. We talk about nitrous oxide. Oops. I think that was the last question. Oh, here we go. Sylvia, she says, I'm 30, never had a baby. This sounds scary. So much respect for moms. It is scary your first time. Would you agree? No matter what, no matter if you're an OBGYN or an L&D nurse like us, I was scared. Were you?
Absolutely.
Yeah.
Oh,
so yeah.
And it is totally different being on the patient side of thing versus nursing or doctor.
Yeah. I mean, you kind of have to, you realize just how much, even though we're both trained in obstetrics and gynecology, how much, we just lose all common sense when it's us, it seems like. And I feel like I didn't know anything, right? And
I know. I tell people all the time that I take better care of my patients than I do myself. I need somebody to take care of me.
Yeah, for sure. So yes, it is scary. But, women do it. But again, while we're at it, I'm just going to put it out there. It's not for everybody. If a woman does not want to have children, that's perfectly fine too. Okay, yeah. That's perfectly fine too. What happened here? Let's see. Here's a question. I am having a scheduled C-section due to medical reasons. I'm not allowed to have a regular delivery. Would it be odd for me to ask to have a doula in the OR with me? So I'll answer and then you can answer because we're two very different institutions. So we typically during a C-section allow one support person. Unless you have to go under general anesthesia for whatever reason, then we ask that person to leave. So that depends on who you want your support person to be. If your support person is your doula, I don't see why not. But again, that's something to ask where you're delivering, if they will let you have, your spouse or partner and the doula, or do you have to pick? What about where you're at?
Same thing. We allow one person in the OR with mom, and that's to her choosing. Every now and then, if you communicate very early on, then they'll let an additional person in, like a photographer or something. But that was pre-COVID. Now that COVID's come around, it's pretty strict on just one visitor in the OR.
Agreed. And same with us. And then Elizabeth also mentions that, typically the support person is with you. Once the baby's born, they offer that the support person goes with the baby, which means that the latter part of the C-section, you may be by yourself. So is that how it works where you guys are?
Yes.
So, go ahead.
I was going to say right now, even our NICU nursery is only allowing one person in. And so the moms are breastfeeding. And so right now the dad's actually staying in the OR with mom after baby leaves.
Right.
Because they can only have one person.
Yeah. And that's an option too, pre-COVID and COVID. If you decide you don't want your support person, whoever that is, to go with baby, that's perfectly fine. We let them stay in the OR. Again, you need to talk to wherever you're delivering to see if that's okay with them too. Unless there's a complication and, there's been times where I want the support person out because we need to pay attention and, take care of mom. And as long as everything's okay though, if you guys decided as a, whoever your support person is that you'd rather them stay with you, that's fine too.
Yes, same where I'm at.
Okay, so tennis, sweetie, 16. Let's talk about vaginal lacerations. Is it your goal to have a laceration-free delivery, and what measures do you recommend to minimize, avoid perineal tearing? You start that one. Did I say it too fast?
No,
Yeah,
I think letting your body do what it's meant to do and avoiding pushing really early on
yeah.
helps to kind of let things stretch out naturally. But really paying attention when your doctor, because what will happen is the baby's head, it starts crowning,
Mm-hmm.
and sometimes your doctor will put perineum pressure, which is that skin between your vagina and your rectum. They'll kind of put pressure to help not tear,
Mm-hmm.
and they'll coach you through not pushing or pushing, and your nurse will help you too.
Yeah. I
I
mean, I
don't
think
really know of any like herbal anything or anything like
no,
that to help with tearing. I feel like it's just something that's either going to happen
happen.
or not, but we try our hardest to not, help you.
Obviously, the more babies you have, the less likely
Mm-hmm.
you are to tear because you've had a baby come out of your vaginal canal before. First-time moms
Yes.
are more predisposed or more likely to get tears, um, but just because they haven't had their vaginal opening or area stretched to that point to have a baby's head come through the vagina. I mean, think about it. It's a head coming through your vagina. So, the key is, like Kacy said, you don't want to push too early. You want the baby to be down to a good station, and that's based on your cervical exam before you start pushing. Um, what women do, because you push 10 seconds, and you're really going, all full force, and then as the baby's crowning, which means as we start to see part of the baby's head coming out and it's crowning, we don't want you to keep because that kid's head's going to pop out of there, and then you can tear. So once you start
Yes.
getting to the crowning, you got to listen to whoever's coaching you in the pushing. Because a lot of times I'll say, listen, I'm going to tell you when I want you to stop, then I want you to listen to me. And I'm going to say, push a little bit, relax a little bit, and I kind of ease that baby out slowly so that it decreases your risk of tearing. So,
Yes.
and yes, it is our goal now. I was also trained in the day. Again, I'm 46 years old. I've been doing this for 20 plus years. Back when I first was training, it was pretty routine that women got episiotomies. Almost every woman got episiotomy. It's not like that anymore. Okay, we do not feel that every woman gets an episiotomy. I do cut episiotomies but I have to make the assessment, and sometimes I have to make it quick. If I feel that she's at risk of potentially tearing through her rectum or having a major vaginal laceration, I will cut an episiotomy. But that decision occurs as she's getting close to delivery, not when she comes in for induction. Okay, that's kind of what I call a game time decision. So
Yes.
I'm not anti-episiotomy, but I cut them only if it's indicated. I
Yes.
will say, and I'm sure you would agree, I feel that so many women will have a tear and don't ask any questions. All they know is they're getting stitches. All they want to know is, how many stitches did I get? You
Yes.
need to ask where your tears are, because women can tear on the labia, they can tear in the vagina, the vaginal canal, they can tear in the cervix, they can tear in that perineal area, which is the thick piece of tissue between your vaginal opening and your rectum. You can tear around the urethra, which is where you pee. You can tear around
Yes.
the clitoris. There are many places women can tear. You need to ask exactly where you tore, because when you get home and if there's stitches there and you feel something that's where you don't think it should be, you're going to freak out, right?
Yes. Yep.
So, so when a woman tears, how do you counsel them or talk to them about that when you know your patient's had a tear?
I always let them know. I don't ever know how many sutures are there because the doctor
Well, I
doesn't ever
don't
tell
honestly.
me.
I don't
I
either.
know,
I mean, because
but
we do
I.
what's called running sutures. So it's not like we
Mm-hmm.
do stitches. We run the suture. So it's not like I could tell you had 30 stitches.
Right, but a
Yeah,
lot of women do ask me that question,
yeah,
and so I'll just tell them, I don't know how many stitches there are, but they do dissolve
hmm
and they fall out. And depending on your body and your pH level and your moisture level and all that stuff, it could take up to 6 weeks
yeah.
for those stitches to fall out. They get dry, they get itchy.
hmm
The more you can leave them alone, the better. And they may not all fall out at one time. It could
Right.
take, pieces here and there, pieces here and there.
hmm
We recommend sitz baths, which is just a small amount of water in the tub, no soap, no nothing, just a warm bath to sit down, set, and let your bottom soak in the bottom of the tub. But don't wear tight clothes when you have stitches. Anything that's going to rub down there. You want to heal up really good, and so.
And yeah, that's why it's important to ask your doc exactly where you tore, because you need to know that. It's important so that when you go home, you know what to expect. So, one of the things I tell patients, the amount of pain you had that first 48 hours after you've had a tear in your vaginal area should be the maximum amount of pain you have. After that 48 hours, it should start decreasing over time.
Absolutely.
If you get home and 5 days later, it's like, whoop, back up here, or it smells, or you have increased bleeding, or you realize that say you're wearing a pad and you start getting yellowish discharge, you've got to let somebody know, because if you've had a significant tear, it can break down. Okay. It's not very common, but it does happen. So again, I'm in a teaching institution. I tell the residents, a woman who's had a vaginal tear or a significant vaginal tear, it's just like having a surgery, because sometimes we have to do major repairs in a vaginal area, depending on how bad they tore. So we have to be very respectful of that and make sure we educate our patients. So if you feel like you tore and you feel like someone's not relaying the information to you, you got to ask.
Absolutely. And another thing is you're at risk for infection.
Right.
So if you start running fever and you're oozing and down there, whereas you weren't before, that's definitely something to let your doctor know also.
Yeah. There's another question from Leah that said, I had internal tearing, which was likely in the vaginal canal. With my first, how likely is it that it will tear again? Will it be worse tear? What I found, the women that tear worse are the ones who have had bad perineal tears where it may have gone into the rectum. And those are predisposed to tear again, depending on how the repair was done the first time. I have not found that women who have had vaginal tears in the vaginal canal tear again, because now the second time around, it's more likely to stretch more. So, that's why if we have had a woman with like a 4th degree laceration, which is through the rectal mucosa or through the rectum, that we do offer them a C-section with the next baby if they want it, because we don't want them to have that risk of tearing through the rectum again. But that's a whole nother talk, so we won't belabor that too much. Yeah, it's a whole nother talk. Let's see. Okay, all doctors should talk about these so we get better. Okay. That's the truth. Let's see. Okay, is there a correlation between a specific baby weight to vaginal tears? How would you answer that question for rabbit tat?
We have moms that deliver 6-pound babies that tear, and we have moms that deliver 8 and 9-pound babies that tear. However, I would say the bigger the baby, the more likely that it is that you're going to have some trauma down there, because the baby's big and
especially if you haven't had a baby
vagina
before. Yeah. And I agree. I mean, I've had, again, 6-pound babies, and the woman tore significantly. And then I've had a first-time mom who delivered a 9.5-pound baby and didn't even have a scratch. It's all about your body, how your body's made, and every woman's different. And you really don't know until you're there. Like, it's not like go ahead.
Yeah, you won't know even with your second baby. You might tear, you might not, but you just don't know.
Yeah. Okay, so that's the end of the questions. So let's pick it up. Oh, here's a good one. Let's talk about pooping in labor. The big taboo topic, and everyone that's afraid to talk about it. We're going to talk about it.
Yes, let's do it. Pooping. I'm a fan of pooping in labor. I'm a fan because I know you're pushing in the right spot.
And why is that?
When you're pushing, you are pushing down in your bottom and using the same muscles that as if you were constipated, muscles to push out a baby. And so if I can see rectal bulging or a little bit of stool coming out, I know that you're pushing in the right spot. So even if that baby's not moving, I know you're pushing good. It's not because you're not pushing good.
Right.
It's
so
probably more likely a big baby, or maybe the baby's positioned wrong, or sometimes it just takes time.
Yeah. So it's not a bad thing. I know it can be embarrassing, but I'll tell you, we see it all the time. We don't even think twice about it. And it just is what it is. I mean, the day we took the oath to deliver babies, we knew that was part of the package.
Absolutely.
And it's perfectly fine. Again, for me, it's a good sign, because I know she's pushing in the right area. It's funny because there's moms who will, their face is beet red, and I'm like, the baby's not going to come out of your face. So
Yep.
then I know, and we can tell, we do it enough. I can tell where they're pushing.
Yep.
And, but we have to talk you through that and let you know this is how you need to do it. And it's a process. So don't, especially those first time moms, don't get frustrated
For sure.
because
Trial and error.
trial and error, we try different
Mm-hmm.
things. We look at how you're positioned, we look at how you're pushing, and we make suggestions based on that as to how you can change things to make the pushing more effective. Because what we
Mm-hmm.
don't want to do is for you to get worn out because you're pushing everywhere else but there,
Yep.
and you get tired and you simply can't do it. So our goal is to kind of watch for these things and kind of guide you in the right direction.
Speaking of pooping, I'm going to talk
Yes.
about passing gas
Yes.
because it happens, especially if
Mm-hmm.
you have an epidural. You have
Mm-hmm.
no control really over your muscles down there. And if you have gas, then it's going to come out
Mm-hmm.
without you knowing. It's going to be a big
Mm-hmm.
surprise. So
Mm-hmm.
don't be embarrassed. We won't even notice it. We'll just keep on going.
Mm-hmm.
No big deal.
It's funny. I have been doing obstetrics for a gazillion years, and I can see all that and not be phased. But if I see someone vomit, I'm bolting out of the
Vomiting is
room.
bad. Mm-hmm.
I can't, and I don't know
Yeah.
why. Or if
I
I
don't
see a
either.
bunch of snot, I don't know. I think we're kind of
Yeah.
crazy, but that's just
Snot
us.
doesn't bother me, but the vomiting gets me every time.
Oh, yeah, yeah.
Especially if they've just eaten or something. I'm like,
Yes, yeah.
like, where's the vomit bag?
Even the sound of it, I'm just like,
Mhm.
whoa, I gotta go.
That's funny.
So, yeah. Okay, so let's
I'm with
talk
you.
about round ligament pain. How do you talk to your patients about round ligament pain?
Round ligament pain is common during the second trimester, although it can happen throughout. And it's stretching of those ligaments in your belly. It could be one-sided pain, and sometimes it goes down the side of your abdomen and into your groin. A lot of women will complain of it when they stand up. And what helps with that is a maternity belt sometimes, or helping lift that weight off of your belly because it gets heavy. But it is painful. It's not something that's just going to stay constant. It comes and then goes away. And then it might come again the next time you stand up. But it's because your ligaments and muscles are stretching out and growing with your growing uterus.
Mm-hmm.
It's uncomfortable.
Yeah, it can be very painful. I mean, actually, one of the most common visits to triage for women is because of round ligament pain.
Yes, they think it's contracting.
They think it's contractions, or I think there's something wrong, and it's actually round ligament. And the way I describe it is this: typically, up until 10 weeks, the uterus is protected by the pelvic bones. Once it comes starts getting beyond 10 weeks, then there's two ligaments on each side of the uterus called the round ligament, and it attaches the uterus to the abdominal wall. So think about it. As the uterus gets bigger and bigger, that round ligament's getting stretched and stretched and stretched. So what you might feel is a tearing sensation or a pulling sensation on one side or the other. It's typically not both sides at the same time. It could be positional. It could be when you're walking or you're laying a certain way, or you make a sudden movement, you might feel it. And it can be pretty intense, okay? So again, it usually occurs in the second trimester once the uterus is getting really big. So typically, it can start as early as 16 to 18 weeks. But again, if you don't know, it's always best to ask somebody. And we're not going to think you're silly by asking, because I'd much rather people ask and understand than sit at home and there actually be something wrong and they were afraid to call.
Yeah, better safe than sorry.
Yeah,
That's what
yeah.
I always tell my patients.
Yeah.
So
Round ligament pain. Okay. Let's see what else we could ask about. Shake, breast leakage. Sex. Let's talk about sex, baby.
sex.
It's really corny.
Let's talk about
Talk about sex.
baby.
I know,
Let's
right?
talk about
All right. So sex. Hit it, Kacy.
I say go for it. You can have sex during pregnancy. The only time you really shouldn't be having sex is if your doctor tells you not to, under certain circumstances, placenta previa, where your placenta is covering your cervix, so you don't want to be having sex for that. Preterm labor, and your doctor will talk to you about this, but otherwise it's not going to harm your baby. It's not going to harm you. It might make you cramp a little bit after, and that's very, very normal. Sperm is irritating to the cervix. And you might spot some after you have sex, and that's very normal. Spotting after sex is normal.
Yeah.
So as long as you're comfortable doing it and you want to do it and everybody's on board, then go for it.
Yeah. So again, the most common reason for a doctor to tell, or two, I would say, to not have intercourse, if there's any kind of low-lying placenta. Elizabeth Chelsea has a low-lying placenta and is on what we call pelvic rest.
Yep.
placenta previa. So placenta previa means the placenta is covering the, remember I talked to you about the internal opening and the external opening of the cervix? Placenta previa means the placenta is covering the entire opening here. Low lying means it's within 2 centimeters of the opening. Okay. So the reason for that is, not because the penis is going to wreck
That's a good
the
point.
uterus and touch it. Okay. The reason why is sperm and ejaculate have prostaglandins. We talked about prostaglandins, which we actually use to induce labor. Okay. So, and the reason why they need that is because the whole thing with sperm is to get up into your cervix and to fertilize those eggs, right? So they need to get up in there. So the uterus and the cervix kind of contract to pull those sperm up. Well, when you're having sex in pregnancy, you still have the prostaglandins in the sperm, even though you're already pregnant, right? So if you were to start contracting and that cervix would start to open, then you could tear where that placenta is and cause bleeding. So that's the reason why we advise pelvic rest on with placental issues. And that is a legitimate and real concern. Don't think that we're just trying to be mean to you. It is a real concern. So if you have a placenta previa or low-lying placenta, you need to listen to your doctor and adhere to that. And it also means nothing else should be in the vagina.
Absolutely.
No, nothing should be in the vagina because you don't want to stimulate the lower uterine segment of cervix to cause it to start dilating and potentially cause bleeding from the placenta.
Yep.
So yeah, so the whole thing with sex, I agree with Kacy. It's as long as you're comfortable and you're okay with it. And I wouldn't try anything new that you weren't doing before. Sex is, and maybe I'm being conservative, but I've done this a lot, and you can agree with me or not. Pregnancy is not the time to try a bunch of new stuff.
For sure.
Do what worked for you before that you know you were good with, and then save that for some other time. So don't start getting adventurous in pregnancy. Wait.
Yes.
Because you don't want to take any chances. Okay, would you agree?
For sure. Absolutely. And I'm gonna
Yeah.
I'm gonna say too, like a lot of times women will come in, they think they're in preterm labor or they are in preterm labor. And one of the questions your nurse is gonna probably ask you is, have you had sex in the last
You had
24,
sex.
48 hours?
Mm-hmm.
And my patients look at me like I'm crazy, and I always tell them,
They get
like,
so offended.
look,
Yeah.
yes, or they're embarrassed. I'm like, look, it's what
Embarrassed. Yeah.
got you here, first of all. Obviously, you're pregnant. But secondly, I don't care. You can have sex. I just need to know because we're going to do a test that could show me whether or not you're at risk for going into labor in the next 2 weeks. But I can't do it if you've had sex or anything in your vagina in the last 24, 48 hours. And so
Mm-hmm.
it's just funny because they look at me like, why do you need to know that?
You're like, you're
And so
being
that's
nosy.
why.
Yeah, you're being
But I
nosy.
don't care. I don't care if you had sex. Go for it. But
Yeah, yeah. I mean,
so,
and again, and and we'll touch on this again. This is a whole nother topic. I have also found that women who have had multiple miscarriages or even one miscarriage are afraid to have sex. And I'm not going to tell them get over it. I'm not going to tell them it's going to be fine. If it's going to cause you mental, emotional anguish,
then
then
don't do
don't
it.
do it.
Mm-hmm.
It's not worth
Yeah.
it.
It's your
So, and that's
body
perfectly fine. Yeah.
Mm-hmm.
You have to be okay with it. And there's a reason a lot of women with pregnancy loss, they are legitimately concerned about that, and that is perfectly fine. Just wait. There's plenty of time to do it after you have the baby. Okay.
For sure.
Let's get to a different time. We talked about sex. I'm just crossing everything off. Let's talk about like postpartum. Let's talk about why does your uterus contract postpartum? What is the bleeding like? What are the, things to look for? When you're sending a patient home, what are some of the things you tell her to look for?
You are going to bleed 4 to 6 weeks after you have a baby, and you will cramp is what you're going to be doing. But what your uterus is actually doing when you're cramping is contracting down and helping to decrease that bleeding.
Yeah.
When you go home, you've had a baby. You might have torn, you might not, but you're at risk for infection always. So if you get a fever when you get home over 100.4, you need to let somebody know. Foul, odor, discharge, funky bleeding that's green or, frothy, any abnormal bleeding or really heavy bleeding is not normal, and you should not be passing clots larger than a golf ball. So if any of that happens, then that's something you need to let your doctor know. Abdominal pain that won't go away with pain medication is another concern. Postpartum depression, I think it's underreported. I don't think women report it as often as it's happening. The blues last for about 2 weeks, and then after that, if you're still feeling very emotional, edgy, or thinking of hurting yourself or others, then that's definitely something that you need to keep an eye out for. Your hormones are crazy, and your doctor can help you with that.
Mm-hmm.
You're at risk for blood clots in your
Mm-hmm.
legs, so I educate them on that.
Yeah. There's a whole lot of things that we need
There's
to,
a bunch.
we think about, the baby's here. And the reason why postpartum education, and maybe that'll be a next topic, we can talk specifically about postpartum stuff, Kacy. But,
Yes, let's do it.
you know, uh, women go through a lot to have their baby. And then everybody, the people that see you walk in the hallway to leave with your baby, their friends that are coming over, your family members, all that attention's on that
It's
baby.
all about the baby. Mm-hmm.
And I get it. Babies are cute. A
They
newly
are.
postpartum mom may not so cute. I know I wasn't, but and I'm being a little funny here, but we cannot forget about the mom in the
Absolutely.
postpartum period.
Yep.
So you have to take care of yourself, and you have to listen to your body. If one of your friends tells you, hey, something doesn't look right, if your partner tells you, hey, something doesn't look right, you have to listen and get it assessed, because women are, we're breastfeeding, we're pumping, we're taking care of a newborn. We might even have twins. We might have a newborn and a toddler. There's so much going
There's,
on that the last person we think about is ourselves. But if we're
mm-hmm.
not healthy, who's going to take
Nobody's
care,
healthy.
right? So it's
Yep.
so important. You have to be willing to understand that your health and well-being is just as important as that baby's.
Absolutely. I always tell everybody, I always say, if mom is not happy, nobody's happy,
Mm-hmm.
because, mom has to be happy. And also another thing with, the mama coach, I love babies. I love them, but I love the moms. And that's
Mm-hmm.
part of the reason why I decided to do the mama coaches, because moms need support and they don't
Mm-hmm.
get it after the babies. I mean, they get it, but they don't get it as much. It's all about the baby. And
Mm-hmm.
so
And
it's
and
important.
and I think it's us too. We can be hard to be stubborn about it. I know I was,
For
and I
sure.
remember my twins just come home from the NICU, and we were going to have friends over and meet the babies, and I ended up in the bathroom crying the whole time. I don't even know why.
Mm-hmm.
I didn't even get to see anybody. And my mom was like,
I know.
"Whoa!" Oh, and I'm just like, I
Like,
don't
what's
know what's
happening?
wrong. I mean, because I just hit a wall. I just hit a
Uh-huh.
wall,
And
and
sleep deprivation is
yeah,
huge
I mean,
too.
it's all of it. It's everything. It's everything. So we have to make sure we take care of ourselves. It's so and so important. We're
For
going to do
sure.
about 5 more minutes. Let me see. There's no, no new questions. Let's see. Let's talk about how can you tell if you broke your bag of water? And again,
Oh, this is a good one.
we're going to limit this. I already see two more talks, Kacy, postpartum, and then we're going to talk about before the labor and delivery things to look for. But we're going to talk
Yes.
about term, not preterm rupture membranes, not anything regarding preterm labor. Let's talk about how do you know your bag of water broke when you're term.
Okay, really fast, because it does not happen like the movies. It can happen. It can be a big gush and you will be wet the rest of the time, but it can also show up in a trickle.
Mm-hmm.
So if you'll put a pad on and walk around, and if it's continuing to soak through pads or get saturated, then you probably need to call the labor and delivery unit and we'll check you out. Because
Mm-hmm.
better safe than sorry. Because if you are GBS positive, which is a bacteria that can be harmful to the baby, or you have meconium in your fluid, you need to be seen soon. And so if you're questioning whether or not you're ruptured, it's something that we need to look at.
So I'll expand on that. So basically, similarly, I tell them, if you think you broke your water, first empty your bladder,
Mm-hmm.
put a pad on or a panty liner. Like Kacy said, walk around, and if it's wet and doesn't smell like pee, but it's actually wet like a
Yes.
fluid, then you probably broke your bag of water, or there's a good chance you did. Talking about the GBS real quickly, and again, let's back up. So it can be a gush. Think about
Mm-hmm.
everybody knows what the typical gush is in the movies.
Yeah.
That probably happens maybe 10% of the time. What mostly happens is, like Kacy said, it's like a continual leak, because you have this big uterus and the amniotic membranes are here, and you might have broken the bag up here. And so it just kind of trickles down. Okay. But there's
Mm-hmm.
still water around the baby. So it's different for everybody, and can be hard to tell. And there's many times, and it's okay if you thought you broke your bag of water, but you didn't. Okay. And you'll come into labor
It
and delivery
happens all the
triage. We
time.
assess you. It happens, and it may happen more than once. I've had women who have been in 3 times in 1 week, especially first time moms, and just didn't know. And we do our certain things that we do to confirm.
Yep.
If you are ever leaking pea colored, green colored fluid, especially at term, you need to tell somebody, because sometimes the baby has had a bowel movement inside, which they do, and it's fine. But if they do it really early, and then you break your bag of water and you notice you're leaking the green fluid, that's called meconium stain fluid, and you need to go in. The thing about the GBS, every woman gets a GBS screen in the 3rd trimester, because the GBS is a bacteria. It is actually a normal bacteria in women. But when you're pregnant, if you have it at the time of labor and delivery and the baby gets it, it can cause GBS sepsis, which could be very dangerous to the baby. It is not a sexually transmitted disease. Okay. It's not something your partner gave you. It's a normal bacteria of the vagina, but we know that it can cause sepsis in the baby if you have it at the time of delivery. That's why we give women antibiotics that are GBS positive. So getting that screen is extremely important. So again, if you know you're GBS positive and you're worried about breaking your bag of water, you especially need to go in, because we want to go ahead and get those antibiotics started if you did break your bag of water.
Yep.
Okay. And we'll answer one more question. Is there something you want to talk about specifically that we have not talked about?
No, I'm following your lead, but I wish I could. My screen is thinking right now, so I haven't been able to see you. But I wish you would pop your grill in.
I would, but it's over in the hot. So
we'll have to plan that for the next one.
I do have a grill for 2 reasons. Number one, I live in Houston, Texas, and it is what it is. For my Houstonians that are here watching, you guys understand me. But there is a really popular Houston rapper here. His name is Toby Nwigwe, and that's one of his things. Then a bunch of my girlfriends went to his concert, and we decided to go get one. So I do have one.
That's so funny.
If you follow me on TikTok, you'll see it. And maybe I'll do a video soon showing it. Okay.
You should follow her if you don't.
Again, we talked earlier about how to get a hold of Kacy on social media. For me, the best way to do it is just go to my Instagram, the link in my bio. And you should do this too. Do you have a link tree?
I do.
Yeah. So is that what you? So, and the link tree takes you to everything, so it's easy.
Yes. Yes, I probably am easiest to reach on Instagram.
Yeah, I answer the most on Instagram and TikTok now. So that's where it's easy. It's just because it's easier. I found on Facebook, when people send questions, they get buried so easy, and I can't figure out where they're at. So it's much easier to ask questions on Instagram and TikTok. We'll talk about C-sections really quick. There's a lot on social media about C-sections, about negative things. I'm going to say my 2 cents, and then I'll let you close with your 2 cents about C-sections.
Okay.
Yes, there is data out there that shows that the C-section rate is too high in the United States. However, we have some very sick moms. We have some high-risk moms. We have moms that are older now, and there are indications for C-sections. I cannot speak for every other physician in this country, but I know we do C-sections where I work when they're indicated, and there are a lot of times when it's indicated, okay? So if you need a C-section and you don't understand why, or someone's telling you need a C-section, you got to ask why, okay? And a C-section is not the end of the world. It does not mean you did not give birth. It does not mean you are not a real mom. And I hear horrible things on social media about women who had C-sections, and I simply do not agree with it. And I will never agree with it. I think there are 2 ways to have a baby: vaginal delivery with or without medication, and a C-section.
Yep.
Whatever it happened,
I agree.
And you delivered, you are a mom, you gave birth, and childbirth to me is natural. And I know I get a lot of shit about this on social media because of a video I posted about C-sections and vaginal deliveries being natural. It's because childbirth is natural. And if that means that childbirth was accomplished by a C-section, then I consider it natural. Okay?
Absolutely.
So that's my 2 cents. You want to add another 2 cents?
I totally agree. But that leads me to another thing, and I agree with everything you said. Communication is key in your healthcare, and you do have a voice in your care. The important thing is that you are communicating back and forth between you and your doctor, because most of the time your doctor and your nurses are very willing to work with you and do what's best for you and your baby, but also take good care of you. And so communicate. You have a voice and you have a say in what you want.
Yeah, I
And
think,
C-sections, with that being said, so close to
yeah.
C-sections, your doctor does not probably want to do a C-section on you. And so if they are doing it, more than likely it's medically indicated and to keep you and your baby safe. So not
Um,
something that they're doing out of convenience.
we got 35 seconds. And one last point, we're gonna do more topics, don't worry. But the whole thing about we're getting a shit ton more money because we're doing C-sections is simply not true. It's
Yeah.
not true. Okay. It's better for me that my patients deliver vaginally. Okay. With that, we got to end because I want to save this video. So thank you so much, Kacy. It was a
Thank
pleasure.
you.
We're definitely going to get back together and we'll do some more topics. If you guys want to hear about anything else or another topic, please private message myself or Kacy and we will get
Yes.
on that. All right. Thanks,
Awesome. Thank you
guys.
so much. Bye.
Bye-bye.